It won't snow.
That's you. I'm just going to record it.
All right. Anybody need any assistance with range of motion? Do you know what flexion, extension, rotation, abduction, adduction is? We're good? Mm-hmm. All right. I'm not going to go over it then. ADLs. Do you understand what ADLs is? Mm-hmm. Okay. IDLs. IADLs. Do you understand what that is?
Yes.
All right. Cleaning to me. All right. All right. Assessment. Functional assessment. What does your patient look like? Let's go back to health assessment for a brief second here. Posture, gait, mobility, their strength. Can they do ADLs or not? You remember how to do a head-to-toe assessment? Yeah. Fabulous. Moving on. Your neurovascular. You remember the P's?
Yep.
Yep, we do? Sure. I have one person that says yes. All right, just want to make sure everyone does. Just another slide for the P's. All right. Laboratory tests. Calcium makes sense, right? Bone, calcium. Phosphorus. Phosphorus likes to follow calcium around. And alkaline phosphorate. That's some of the material inside the bone. Your muscles. Kinetic kinesis. Lactate. Aspirate, and allulose. You just need to know your electrolytes. Okay? Just for the test. Just your electrolytes. I don't care if you know your muscle. Let's talk about fractures themselves. If you could pick a fracture, which would you pick?
Closed.
All right. Why?
Because it's closed. It's not poking on.
A lot of them are closed. Technically, a lot of them are closed.
It's not shattered.
Not shattered.
It's like it's like a perfect break. I don't know how to explain that, but like
it's a clean break.
Yeah.
We call it a clean break, right? That's the one you're gonna want. Typically, you won't need surgery. You won't need to have us go in there and mess with you. Occasionally, with the oblique, which is the bottom left, you see it's not all the way through. Sometimes we could just let that go and we'll try to cast it if we can and let that roll through. But the other ones, open compound fracture, we're actually going in. A fragmented fracture where you got little pieces everywhere, we're going in. And typically what we're doing is we're replacing those pieces if we need to with bone cadaver. Because if you have a break and there's like a centimeter of these little pieces, we can't get the bone back together. Yes, ma'am.
No, this is not something that I'm sure you would care about, but for Jehovah's Witnesses, my uncle is one, and like he needs back surgery. So like, would you just take out the pieces and leave it and just say? Because they have to consent for it. Right.
You can put bone cement and other stuff in though to try to do it, depending how big the space is. If it's thin enough, we could probably just do it with bone putty and bone cement, and then it hardens just like regular bone. But if it's a little bit larger, the ortho surgeon's going to want bone cadaver. And the same thing as blood. We don't put it in unless they consent to it. Spiral fractures suck. Those are the worst to fix. Impacted, exactly the way it sounds. They go down, they put their palm down first, hits their humerus, it actually breaks the humerus, and then pushes the bones against each other. It is incredibly painful. And then a green stick. Green stick is where there's a chunk missing, but it's not all the way through. All right. Different types of fracture diagnosis. What is our main way to diagnose fractures? X-ray. All we need. A surgeon may order a CT or MRI, depending if they think a ligament or a tendon might be involved, that we also have to fix. That does happen. Or if they're complaining of pain, and it sounds like it's a fracture and there's no fracture, we'll do an MRI to see if they ripped or tore a ligament or tendon. Same type of pain. All right. The skin versus skeletal fractions. Anybody ever seen an external fracture device? What is it? That. Yes. Who did the Halo Sims on Monday?
So bad.
Okay. Halo Sims, same concept, right? You got to keep the pins clean. You got to keep the incision sites clean. This is a temporary thing. Depending on what bone it is, they will stay in the hospital until we can take it out. Halo individuals actually can go home pretty relatively fast. When it comes to just skin, the top left, the tib fib is fractured. That is a cast, And we're using a weight belt to do what? Hold traction. We don't want them moving around too much. We want it straight for a while. So what kind of care would you want to be watching for someone that's in traction?
Temperature.
Amazing. Why temperature?
Make sure there's no infection.
Extremely infectious.
Yep. Bone fractures are extremely infectious. They're one of the highest infection sites that we have in the hospital. That's why typically ortho units have their own units. They do not allow medical patients on an ortho unit. Last thing you want is a total hip next to a pneumonia patient. Alignment. What's your 5 P's for circulation?
Feeling, currency, the ones that came around.
What's the 5th one? Go back to
Did
me.
you say Polaris?
What?
What? I don't know what's been said.
Pain, power, paralysis, pulse. Which is what?
Paralysis, parasympathesis.
Which is what? Sensation feeling. Good. All right.
I'll just say sensation.
All right. And why do you need to increase fluid intake?
Calcium.
You keep everything being flushed. They can't move right now. All right. Let's talk about a hip fracture. There is multiple people out for debate. What comes first, the fall or the fracture?
Well, depends if they fall on their head. If it's an old Grammy, it's probably already fractured. When she falls, it just fractures.
They are seeing more and more the reason people fall is because they're bone fractures. The more and more we're looking into it, the fracture is older than the fall. That these people are actually just fracturing their bones, daily life, and their bones just break, then they fall. It is not the other way around. So the other way around is the catalyst that, you know, because how many people do you know, like, yeah, my leg kind of hurts during the winter. Yeah, it's because you broke it and you don't know. Because one of the little hairline fractures, if you don't do anything to it, it will eventually heal and it will be fine. I had a friend that she broke her foot in Israel and had no idea. She was visiting Israel, they were walking around, she stepped weird, her foot hurt for a while, and then she came home, and after like 3 weeks when it was still like swollen, I went, yeah, I would go see a doctor. It was just me. And sure enough, she had broken 2 bones in her foot. So some people, the fracture tends to come before the fall. Any questions on anatomy of the hip? This is one of the most common surgeries we do to put the hip bone back in place to the pelvis. There are times where it's just easier just to do a total knee replacement. The way where it's broken in the ball socket joint, it's just easier to move everything and put a brand new hip in. So a lot of times you'll see that too. This is what's called an ORIF, which is an open reduction internal fixation of the hip. And 99.9% of the time, the person keeps that in for forever. That is theirs, we don't take it out. Can you guess the only times we take it out?
Infection.
Infection and?
Rejection.
Nope.
Pain.
Nope.
Replacement.
Growth. You can have a little younger individual break their hip, and we will take it out once their bone starts to increase. So post-op care for hip fractures. Does anybody know the biggest complication with hip fractures? It's not infection.
Keeping the legs
PVT?
apart.
Yeah.
Yes, and what's that called?
Abduction.
Abduction. Why?
Because the way it sets, you have to set it, and if it's in, it's not going to set right.
Right. So if you rotate your person that just had a total hip replacement done, if they rotate their leg a certain way, the new hip joint can pop right out. It happens all the time. I had the sweetest couple in the world, like 10 years ago, come through the ER, and my ortho surgeon called me, and we went down there, and this beautiful older couple, they were like in their 70s, and she had popped her hip out of joint. Anybody want to care to guess what the activity was they were doing?
Sex.
Yes, they were having sex. So they were both so embarrassed. So it felt horrible. We popped it back in. She was home that afternoon. It is possible just to pop it back in. We'll give them some fentanyl, some Ativan, and we'll just pop it right back in. So there is that particular procedure with the hip fracture is called the posterior approach. That's actually where we cut it open from the side. You can do the anterior approach, hip fracture or hip total replacement. Not everybody is a candidate for that. There are certain criteria people have to meet, but in that case, the complication of the hip popping out is non-existent because of where we have gone in and where the muscle is weak at that point. So the different ways that they can get up right away is pretty nice.
Isn't there, it's better, like there's like less healing time on the...
Interior, if you can do it, if someone can do interior, we highly suggest it. The healing time's less, the complications are drastically reduced.
Why would you be able to do that?
An interior approach, why?
Yeah, like what would make it so you could? My husband had one when he was 30. I wonder why they didn't do that.
Isn't it because of what muscles you're cutting?
It depends. Yeah, that's why. It's because of the different muscles we're cut. But like the qualifications, it has to do with an age factor. It has to do with obesity factor and medical history. If they have any sort of different clotting disorders, some of the surgeons will do it because it's closer to the femoral artery. It just depends. But it has been proven. Dr. Lutz at Kenosha does interior approach anytime he possibly can. So it's just better for everybody. It is a relatively newer procedure though. It's only been going on about 15 years.
Oh, 7 years ago he did it.
Oh, okay. Who did he have?
We live in Kennel, so we were.
Oh, okay. Some surgeons won't do it. Some surgeons don't know how, and they just won't do it. And sometimes that's as simple as this.
Yeah.
Lutz is the only person around this area that doesn't. The anterior approach. Everyone else does
back to
posterior.
the other one, I'll have to ask.
Yeah. You need a special table to do it too. And, you know, it's about $100 table. So.
Yeah.
Yep. So, all right. Post-op care. You guys can go back and read these. Make sure you look at your nursing care, which is in the bottom center, please.
Hint, hint.
Hint, hint. Joint replacement. What should the nurse assess pre and post for any joint replacement?
Pain, range of motion.
Mm-hmm. What? Infection?
Self-care.
Self-care?
I'm reading off your screen, it's really hard to read.
I know it's kind of, I should change the background.
Progression of activity.
There you go.
Prevention complications.
Yep.
DVT and PE.
DVT and PE. So if you had a total shoulder replacement, where would the DVT and PE, where would the DVT show up? Excuse me. Shoulder, where would the blood clot show up? In your arm. Typically shows up in the arm. PE will show up, you know, where it always does. Say hip and knee, you'll typically show up in your calf, all right?
So Holman's you check is the sign for PE in the leg. What's the what would be the?
There isn't one.
For the arm? And
a lot of people are going away from Holman's in the calf because it only really has a 50% accurate rate. So about 100 people that have a DVT in their calf, Holman's only shows 50%. So they would really just let them into the lab and do the ultrasound just to really double check. So, patients with amputations. For swelling purposes, and really just throughout their entire life, what is the best way for a leg amputation patient to lay?
On their back with their stomach.
Nope.
What do you call it?
How does a leg amputation patient, what's the best way for them to lay?
On the side.
Nope.
On their stomach?
On their stomach. The best way for them to lay.
Why?
Helps prevent any clotting factors. It helps increase circulation. It helps with their muscle strengthening.
Isn't there a risk for SIDS? Just kidding.
Never know. Depends on the patient.
So it prevents clotting?
It helps strengthen the core and those muscles there. Because when you lay on your stomach, what are you constantly using?
I should be really skinny then.
Your abdominal muscles, your butt muscles, your thigh muscles. That's why babies are, the pediatricians tell parents to put the baby on their tummy, helps strengthen their core. And most children hate it. My daughter just looks at me like, you hate me. What is something we see with post-amputation patients the most? Oh, there it is, phantom limb pain. No, it's not swelling. Phantom limb pain. What is phantom limb pain? This is a real thing.
I've heard
but
ghost
it's
pain.
really not
They
there.
feel like they have pain in part of the leg or part.
That, just what Angel said. They feel like they have leg pain, but the leg's not there anymore.
Yeah.
We treat this.
With a mirror.
No, we treat it medically.
Yeah.
We'll give medications for it. Because what is hurting? There is pain there.
The nerve.
The nerve endings have not dulled yet. So there is pain. So until those nerve endings dull out, which there's no real time frame for it, they will experience pain. So let's talk about the 4 phases of body image. Impact stage, number 1. Typically nobody's horribly excited about having a limb removed. So you have the despair, the discouragement, the anger, the hostility. Phase 2 is regression behavior or denial. I have had patients deny that they had a leg amputation. Acknowledgement phase, the morning of the loss. Listen, it sounds kind of weird, but if you're 50 years old and you're in a car accident and you lose the bottom half of your right leg, you have lost a part of you. And there is a mourning process to go with that. Because before you can get to the acceptance and figure out how to treat it, figure out how to maybe put a prosthesis on, go to PT and OT, you have to mourn it and then accept it just like anything else.
Do you think it's different between like what the reasoning is? Like for like your diabetic patients who I don't feel like the ones that I've seen, they don't really
Non-compliant.
If they're non-compliant, and typically at this point, most of the patients I see that are losing toe, it starts with a toe or two, goes up and goes up, goes up, they don't care.
Yeah.
They're at the point where they don't care. I rarely have impacted a patient that had a limb removed because of diabetes and they cared. So they're like, oh, it's just part of the disease. Here's the problem is nobody has to get that far. And so rehab. Rehab is very important when it comes to a limb loss. The first thing a patient has to do is have the drive to want to do it, because their life is about to drastically change. Especially as easy as, you're old enough to drive, you just lost your right leg, how do you drive now? Most people I know use the brake and gas with their right leg, even if they're left-handed, right? Think about how you drive. Are you using one leg, are you using two, or are you using the left foot? Most people tend to use the right foot. Well, how are you going to learn? You have to relearn how to drive. So do yourself a favor. Go into a parking lot. Don't do this on the highway, because I don't want you blaming me. Go to the Walmart parking lot when no one's around and try to do it with your left foot. Bring your right foot up, get it underneath this chair a little bit, and try to use the brake and gas with your left foot.
I've done it.
You get cramped.
It's hard. It is because your body constantly wants to bring the left leg forward, because it's so used to it.
I drive so much, I taught myself to
What
use
if
the
a
boat so
manual?
I get tired.
And it does
You
happen.
never
Yep.
drive manual
I
again.
did. Oh, yeah. I lost it.
Right. Understand the different nursing diagnosis for rehab when it comes to limb loss. If you could please also add risk for impaired skin integrity, because taking care of the skin for a limb stump is different than just regular skin. Okay.
Risk for impaired skin
Integrity.
That's why that guy makes those things that I gave you.
Mm-hmm. All right. Metabolic bone disease. Any of these sound familiar?
Yes.
All right, we're going to get into them, okay? Osteoporosis risk factors. Alcohol use, corticosteroid use, right? Because corticosteroids like to eat up the calcium. Just low calcium in general. So every single person here, you have low calcium in your body probably. Even if you're normal, it's on the low side normal. Low estrogen, smoker, and sedentary lifestyle, which means you just sit around a lot, you don't do a whole lot, you live in Wisconsin, and just snow in April, so you can't get outside. All of those. Why do individuals that get older tend to get shorter as they get older? the vertebrae does two things. It either starts to compact, or the vertebrae actually starts to thin out. So yes, people can, not everybody, but people can get shorter. What are some high calcium foods? Pudding.
Cheese.
Dairy. What's higher than just dairy? Spinach. Spinach is very high in calcium.
Spinach is just like the superfood now.
It really is. And apparently kale is too, but I can't get past the bitter taste.
That's why she never says it. You ever notice that?
Yeah, I can't get past the bitter taste of kale. I tried.
Even like when you put it in the.
No, it just has that bitter taste to
I
it.
agree.
I just can't handle it.
I don't like spinach because
I could put in a bag of spinach in my smoothies, and it tastes like strawberries, but it's green. I put a little kale in there, just forget it. I'm just not. No.
Stomach.
All right. Osteomyelitis. So soft bone. Why would you get soft bone?
Vitamin D deficiency.
Why do you get vitamin deficiency though?
Celiac disease.
There it is, celiac disease, and
Kidney and liver dysfunction.
And?
Anti-eleptic use.
that's why you get the vitamin D deficiency though.
Okay.
Okay,
Could it be genetic too or no?
it could be genetic. Genes will always get you.
So
And-
kidney and liver dysfunction, what else?
It's on the slide, honey.
It is?
It's right there.
It's on there?
It's on the slide, bottom right corner.
Y'all just thought I was real smart for a second.
It's in the picture, Gwen.
It's in the picture
Found
underneath the
it.
two bone. Yeah, sorry. That is typically why you get vitamin D. Now, by all means, we live on the northern side of the Mason-Dixon line, which means we all have low vitamin D anyways, right? I cannot stand, I don't mind when it rains, but I wish it would rain and the next day the sun would come back out, but we don't have that here. It rains and it's cloudy, then it snows, and it rains and it's cloudy, and then it sleets, and it's
And then
horrible.
we see sun for 3 days of the year.
Yes, so,
Is celiac disease because of the gluten deficiency, so that way they can't eat things that have dairy, so is that why? So, because my
Well,
sister has
they
celiac,
can eat
if she
dairy.
took a
speaking of
vitamin-
dairy,
I mean,
Sweet.
like the wheats and all that, like.
it's possible.
Is, okay,
So,
just cause.
When it comes to celiac disease, there's a lot of things we don't know yet. And if you do any research on it, are you okay?
I'm just old and I need to see it.
Oh, that's fine, okay, as long as you're okay.
Osteoporosis. Yep, pretty much.
You'll find a lot of people that have true celiac disease also are lactose intolerant.
And she also has to take anti-epileptics too,
Yeah.
because of the celiacs. So it's like she should probably start taking vitamin D.
If she is not on a calcium vitamin D supplement, she probably should be.
If I only take calcium, I should take vitamin D.
You really should.
Mm-hmm.
They're in conjunction.
But you can get those little chews that kind of taste like Tootsie Rolls
Yeah.
that have both of them in there.
That's what I
You
think.
also
Yeah.
can't beat the part.
Don't you also need vitamin K too? to
Women,
help?
more women do than men, around here especially.
My calcium pills are this big.
There's chewables. They're delicious.
Yeah, they're like little Tootsie Rolls. Yeah, they're great.
They've got caramel ones and they've got
Yeah,
chocolate
you
ones.
should really try them.
Well, hot dog.
That's what I take.
I'll bring some next
Sugar
week.
candy.
All right. Paget's disease. What do you know about Paget's disease? It's awful, by the way. Painful. The bone though reforms not in the normal way that you would think. Like if you break a bone, the bone reforms and it's actually stronger than it was before. When it comes to Paget's disease, the bone forms in callus forms. So if you think of the femur, all of a sudden the individual breaks part of the femur and it's forming like a callus over that. So it can get quite painful. So what would some interventions need to be done for this patient?
Pain control.
Pain control.
Sedentary life.
Actually, you don't really want them to have a sedentary life.
I was just kidding, like Bubble Boy.
Total joint replacement.
What's that?
Total joint replacement.
Possibly total joint replacements just to help the joints out. But we can't make, oh, his name just escaped my brain. The $1 Million Man, okay. We can't do that. So why would we increase calcium and vitamin D?
So they don't break their bone.
You want to strengthen. The less you break in the bones, the better they are. Simple as that. right, osteomyelitis. What do you know about osteomyelitis? It's gross. Okay, we're done.
Really, really good.
It's infection of the bony tissue. It is very hard to treat. People don't typically seek help right away because it really just does look like a blister, or they think it's I need more caffeine. What is the disease process that with the acid that swells up your toes?
Oh,
Gout.
Gout, yeah. People a lot of times think it's gout because look at where it's at.
Mhm.
So they assume it's gout. And by the time they really do seek help, it's the infection's already invaded the bones. And by that point, we're just removing toes and feet. Okay? So what are some nursing diagnoses that would be a part of osteomyelitis? Definitely paired skin deterioration. What else? Possibly body image if we're taking stuff off.
Could it be activity intolerance because of the foot?
Absolutely.
What was that?
Possibly activity intolerance. If their foot's constantly hurting, they're not going to be getting up, walking around. How about ineffective tissue perfusion?
That's what I said.
Because you're way back there. You need to speak up. And then just pain. Acute and chronic pain.
So does it always present with that blister then?
It does not. Sometimes it'll just be swollen.
So it could be confused with like cellulitis?
Absolutely.
Okay.
Yep. All right, your nursing interventions. They definitely need antibiotics and pain management. Why would someone be on contact precaution?
Infection.
This is an infection, and it's one that likes to spread fast. St. Luke's is using the Bariatric Oxygen Therapy Treatment Center, and that is doing very good things. If you have no idea what that is, you need to YouTube it. It's a phenomenal thing.
Where's St. Luke's?
Milwaukee on 27th.
You talk about it, I just didn't know.
They do a lot of fun stuff there.
Well,
And then surgery. Okay? This is a patient that's going to be going home on long-term antibiotics, so they'll have a PICC line in. So make sure you review your PICC line and central line stuff. All right. Tell me what you know about RA.
Sucks.
It sucks. Okay. Autoimmune disease, correct?
Really painful.
It's very painful. You see? Can you see the pictures from the presentation after 5 years and 15? That's the same patient.
Wow.
Yeah, it's bad. There's not a whole lot that we can do. We can't do anything to stop it. What can we do to help slow it down? Pain management. What'd you say?
my daughter takes something, but I can't remember what it is.
Isn't like Humira work for it?
pill?
There is a pill.
Is it called methotrexate? Is it the right one? No.
That's one of them.
Okay.
They take NSAIDs, they take steroids,
Mhm.
they take salicylates or whatever.
Yep.
Biologics?
They're also not as much biologics as right now. At least not last year that I read. A lot of patients will complain of fatigue because this isn't just affecting the hands. That's what we take pictures of the most. It's affecting everything. So this is the patient that we encourage to rest. It'll just give them more energy throughout the day. If they're up in the morning and they're moving around, they can rest. They'll just feel better at night. You don't want someone with the autoimmune disease to get exhausted because then
Can't
it will automatically get worse.
So you wouldn't want to give somebody like this, like corticosteroids, because that's just going to make it even worse. So like even if they have like asthma or any type of respiratory disease, you'd rather treat them with something else.
If you can. If you absolutely have to give them some steroids, it needs to be high doses, quick, effective, and off. So you really don't want to. Also with this type of patient, because it affects the joints a lot, if you notice all of the patient on the right, all the joints, you don't want this patient doing a repetitive job. So let me tell you, if you have a patient that has RA and they've been just diagnosed with RA and they're a billing and coding person, so all they're doing is on the computer all day, right? This would be bad for them. You don't want someone that's constantly doing the repetitive motion over and over and over again, because that will tear down those joints and those part of the muscles faster with the rheumatoid arthritis. Obviously, you can't tell someone to quit a job, but you can advise them of how to delay the progression as much as possible.
So I'm just wondering what's wrong with that first picture? Because that first picture looks like a normal hand.
Yeah, that's why.
Is
It's
she
the
just
progression
like
stage.
joint pain or?
They just had joint pain. They just came in and their hands were hurting.
I saw that freaked out with somebody with rheumatoid arthritis. She had big knuckles, so do I. I'm done.
No, that was like, think of that as present day. Like, okay, you just got diagnosed with this.
Okay.
So not a whole lot's happened yet. All right, this is just pictures of the different inflammatory responses. Well, and the joints like to swell up on you. All right, different deformities. These are the different ways the hands can go. The one you see the most is A. You just kind of see like the little joints and the fingers kind of go every which way, and they can't close their fingers anymore. B, it looks like you're pressing down on something, but that's how their hands are all the time, and it's always painful. C looks like gout again. That's why it always gets confused with this. And then D the same way. Okay? All right. These are all the different things you can see outside of just the joint issues when it comes to RA. So what's one that we typically see in surgery a lot that we can fix, we can actually do something about? Carpal tunnel, yep. Carpal tunnel release. We can do that. It will help them out for several years. You actually can do carpal tunnel releases often too, because that ligament that we actually are affecting in the wrist, that actually will heal itself, and then we'll just go and do it again. So we can buy people some time from the progression. So what are some diagnostic studies you're going to do with RA? Not right away. Lab work. Lab work's your big one. So you're going to actually look for your rheumatoid factor. Is your rheumatoid factor high? If it's not, you don't have RA. Then you have the SED rate. Again, what does the SED rate tell us? If there's inflammation. How bad is the inflammation in the body? Very good. Then the C-reactive protein, the antinuclear antibody, and then the ACPA. Those all have specific roles when it comes to RA. Then what we can do is get actual synovial fluid. We'll actually pull that off to see what kind of cells we're dealing with, and then we do the x-ray of the joints. See how bad the joints actually are. Okay. Then we'll be able to tell how far along they are.
Which tests for a test would be most important? The RF?
The RF is going to be the first one they do.
Okay.
Yep.
What was the sediment one?
The sediment is the inflammation, presence of inflammation. All right, different drug therapies. So, decreased permanent effects of RA. There is no cure for RA. The medications we have are just to decrease the effects of the disease process. Methotrexate is typically the one you hear. This is the one that's on TV. This is the one everyone hears. It is important for the patient to start, if they choose to start the medications as soon as possible, because it has been proven that these 4 medications listed, mind you, they only need one. They won't be on all 4, just one. Will decrease the long-term effects of RA. Think of it as it's helping block the disease process from implementing as severe. All right. So different ways they can help themselves out at home. Relieve the pain. They can take NSAIDs. This isn't someone that's going to have narco or oxycodone at home, okay? Stiffness, muscle spasms. Ice is listed because when it comes to joints, ice is the preferred treatment. But if heat's what takes away the pain, they can do whatever they want. Some people use ice. Some people use a hot pad. Some people take a bath. It's whatever is working for them. Some people have noted that when they take a shower or hot bath, it worsens. Some people notice it helps. Typically, when there's actually an exacerbation of the disease process going on, typically ice helps the most because it's inflamed, so ice is going to help with inflammation. All right, you guys okay? Mm-hmm. We got like 14 slides left. You want me to just hit it?
Yes,
yeah.
please.
All right. Fibromyalgia, tell me what you know.
Pain.
Chronic disorder.
Chronic pain disorder. Tell me what you really feel about it.
It's fake.
Nobody's been able to prove if this is actually real or not. Because what the individuals say that think that it's real will say, well, what's a neuro problem? Really? Because I can prove ACL, I can prove ALS, I can prove a stroke. Individuals that have fibromyalgia, does anybody care to guess the #1 effective, proven, evidence-based treatment for it?
The water with a Benadryl tracer.
You wish. Or your patient wish.
I was thinking the same thing.
That's what they tell you. But what?
Marijuana?
Nope.
No.
No. Not even close.
Sunshine.
No medication whatsoever.
Exercise.
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 I'm gonna tell everybody now.
Just get up and walk
Buddy. It's
a
got-
half an hour 3 times a day. You will never be in pain. We had, in the early 2000s, we had a certain medical professional up in Racine at All Saints, he's retired now, who was sick of people coming in for complaints of quote-unquote the fake disease, fibromyalgia. That's what he told me. So he would just write them narcs prescriptions to get them out of the office because he didn't want to deal with them. We had a massive amount of people coming in for drug overdoses from fibromyalgia because nothing they took, nothing they did was working, so they just kept taking the narco over and over again. And I'd say, well, do you get up and walk, which is actually the first effective treatment? Well, no, I'm just in too much pain. Yes, because you're not moving. People that, if you have any kind of stiff joints or muscles, typically movement is the thing that helps the most.
Munchausen's is a hell of a disease.
All right. More symptoms that are coming out of someone that has a true fibromyalgia case. Now, if someone has a true fibromyalgia case, the nerve endings are affecting almost every body system you have. This is how people are actually being diagnosed with fibromyalgia. Everything else is being ruled out. They're still having almost all of these issues, and nothing's working. And then we make them go to physical therapy for an hour a day for a couple weeks straight, and that's on Saturday and Sundays too. And if they feel better, they have fibromyalgia. It's really what they're doing. So the patient's fatigued, they have headaches, they have IBS, they have persistent widespread pain, they're depressed, they have memory and concentration problems, and they have sleep disturbances. Well, I can tell you right now, that's me, so I don't know what to say. And I don't have fibromyalgia, I have a 7-month-old. So I'm not really sure, but that is the prerequisites for fibromyalgia. No doctor I know at this point in time will give anybody with fibromyalgia any kind of opioids. Not any. They won't prescribe any kind of opioids or narcotics. They may prescribe a neural medication. Anybody know what a neural medication would be?
I
Give
get
it back.
gabapentin.
Yeah.
But I don't know. I just have a bad shoulder. She's pain down my arm and leg.
When I first hurt my back, I had all that nerve pain. I was on gabapentin for about 1.5 years. It was the only thing that helped take the pain away. So that's what we're finding. And when that's being said, if the gabapentin or Neurontin's working, guess what? It's nerve pain. So, all right, osteoarthritis. What do you know about osteoarthritis? Pain and where? It's joint disease from wear and tear of the muscle. It's the most common form of joint disease we have in this country. It's because we really don't take care of ourselves. Nurses, side note, have a very high osteoarthritis disease going on. It's because of injury, frequent kneeling and stooping.
Like they
Sound
yelled
familiar?
at me for
Yeah, I did. I yelled at all my students, stand up or sit down. Don't lean. I do not want you to go through what I went through. All right, the actual patho changes. It's the picture, the part of D slide, that's the picture of the gentleman that has osteoarthritis. Not as bad as the other one, but still you can see the swollen parts of the joint and the joints that are popping out. The synovial fluid in osteoarthritis is completely normal. What osteoarthritis is the destruction of the cartilage in the joint. So then the space narrows, then there's inflammation, then it swells up. Okay? Make sense? That steps make sense? Right, what are your symptoms?
Pain.
Joint pain?
Stiff.
You're stiff when you first move. So you can be walking around all day and be absolutely fine. It's when you like kick your feet back and go see a movie and put your feet up in those amazing chairs, and then after like 3 hours you can barely move, or you're getting out of bed and you're real stiff. Joint swelling, the cracking, crunching. Oh my gosh. When some of you like crack your knuckles, it freaks me out. I'm like, oh my god.
When I've been down, my knees crack.
Is that you? Yeah, you crack your neck. Oh.
My husband cracks his neck all the time. I'm like, you're gonna need a halo brace by the time we're retired. All right, manifestations of joints. These are the joints that are most commonly affected. I don't care if you know the slide or not, just there. So how does one live with osteoarthritis? 27 million people have it in the country. That's just the country. So what are some things people can do?
Weight loss.
Weight loss, always good.
Eating cream.
Always good. Stop drinking. Those 3 right there, you should be good. What kind of pain medications would someone use?
Tylenol.
Just Tylenol. We don't want NSAIDs with this type of patient, okay? Low impact exercise, so any cardiovascular, swimming is typically the best. You can get steroid injections for when it gets really severe. I think you guys already listed your nursing assessments a minute ago, so I don't think we have to redo those again. All right, rheumatoid arthritis versus osteoarthritis. What is the difference?
One has
Yep, arthritis, the osteoarthritis, the synovial fluid is basically gone. So with the rheumatoid arthritis, the synovial fluid's there, but it's inflamed. Okay, so that's the big difference.
In rheumatoid arthritis?
It's virtually treated almost the exact same way though, treatment-wise. All right, what do you know about lupus?
it's autoimmune.
Inflammatory autoimmune disease. It's almost always genetic, but you can get some hormonal factors, some environmental factors that may affect it. What's your patient going to look like?
Red.
Reddened. Their skin is reddened. They're very prone to heart issues and pleural effusions. And what gets enlarged when it comes to lupus? What organs get enlarged? Lymph nodes can.
Is it the heart?
Kidney.
Why do people with
Kidney.
lupus have
Kidney.
heart issues?
I don't actually know.
Okay.
It's just, I don't know if it has anything to do with the fact that the kidneys aren't working as well. So then the heart and lungs have to work harder to keep everything moving. So lupus issues, because of their reddened skin, they absolutely need to wear a lot of sunscreen when they're outside. And do you guys know if you wear sunscreen, how often you're supposed to apply it?
Like it's really fast.
It's like every 80 minutes. It's like virtually every hour you're supposed to reapply it. I found this out when my amazing fiance, we all went boating and fishing one day, and I kept putting sunscreen on because, you know, I have the white shade of Casper. Well, he has lighter skin than I do, and he had 2nd-degree burns on his shins.
Oh my god.
Because he put it on the once in the morning at 9 a.m. and never reapplied it.
I fell asleep for 3 hours in Hawaii on my stomach, the back of my legs. I couldn't even walk.
Oh,
I can just imagine what that feels
Oh,
like.
it was horrible. Like, to watch him put on socks and shoes to go to work, I cried. Because it looked like it hurt so bad. And there's not a whole lot you can do. You can just treat the burn. And then he would take, you know, Advil or whatever he wanted to take that day to see if he could loosen it, loosen the pain. But for like a week, he was in a severe amount of pain.
Give him some Silvadine, he'll be cool.
Right. I would have it.
It's expensive in Vegas.
Yeah, it is. All right. So, the different multi-systems that involve for lupus, the very typical butterfly rash you see on the face, but they can have any kind of erythema anywhere over the body. But the face is just the most common because it doesn't matter where you live, the face sees the sun the most. Different heart issues, different urinary issues, muscle issues, neuro. This is a rough disease because you never really know where it's coming from or what could be affected. So when it comes to lupus itself, guess what? There is no specific test we can do. So what do?
History.
We do history and family history. What else?
You don't take blood?
We can, but the anti-Smith lab test, only about 30 to 40% of people that have lupus have the.
I know, like, when they're, like, looking for my shoulder, they mentioned something about lupus and RA, they ruled all that out, but I remember them talking.
Yeah, the anti-Smith antibody that is associated with lupus, only about 40% of people that have lupus have the antibody. So they will take it, but it's not.
Okay.
It's not like, oh, you have an infection, your WBCs are elevated. They're not that nice. What typically happens is it's a rule-out factor. We start ruling stuff out. And usually if RA is the last thing on the list, that's typically what you have.
What's ANA? It says ANA is present in 97% of persons with this disease.
Here, it says nursing associates.
It is not the nursing associate. Anybody know what it is? It's not. It's not important for the exam. Let me look it up though. She just know by now. Should ask. You should just look it up. While she looks it up, what is our drug option treatments? NSAIDs for the pain. What else? Steroids. Steroid sparing drugs. So that's why corticosteroids are listed. Thank you. Drugs help with this too.
It's anti-nuclear antibodies. And then it means if it's positive, it's an indicator.
Yes.
Okay.
But it's not the end-all lab test though either.
Yeah, the autoantibodies are present.
Yeah.
Sweet.
If your patient is suspected to have lupus and their BN and creatinine levels are elevated, this is something you need to let the doctor know because the kidneys are now very much affected and we've got to do kidney protocol after this. All right, any questions? It's either A, B, C, or D.
Oh, wow.
A and B or B.